Thank you, Scott, and thank you for inviting me here today. So I have another disclaimer. I'm an anesthesiologist and intensivist and not another oncologist. So it's interesting in this last session on the solutions, so far we've heard from now 3 non-oncologists to come up with some solutions. Scott did challenge us, and he said, talk about solutions. So I want to talk about a potential solution. We don't have the answers yet, but we're very excited about bundled payment for cancer. We think it has a lot of promise. We've been working on this now for 4 years at MD Anderson. For the last 6 years, I've had the honor and privilege of running a Institute for Cancer Care Innovation that attempts to demonstrate the value of MD Anderson's unique form of cancer care. Why did we have an institute devoted to demonstrating value? Because we think we have great outcomes, but we can't prove it. And we know our costs are high, and we need to address both. And so let me talk with you a little bit about what we're doing, and I want to harken back to some work that's been done here, led by Patty Gans and Laura Levitt and Aaron Ballo, who are in the room, who are the authors of this report, and talk a little bit about the conceptual framework where we started talking about this a couple of years ago. I want to give you the landscape of what are the current initiatives about episode-based payment. I want to tell you a little bit about our approach and a current pilot that we are developing along with a payer, not CMS. And then, as we were asked to do, talk about some of the challenges and barriers that we see to episode-based payment. So, a little bit of context. Again, no slides about the costs, but the fee-for-service system has been blamed for our national health care cost crisis. And I don't think we need to say anything more, except that with an episode-based payment scheme, our hope is that we're going to move away from paying for the volume of care that we provide and for expensive procedures and being reimbursed for the cost of the care that we provide, including the drugs. And again, I'm going to sort of point out to you that in MD Anderson's budget, when we bring people into MD Anderson, we provide everything. The drug costs are a small fraction of the total cost of cancer care. And so while I've been very appreciative of our anxieties about the cost of care related to the drugs, there are a lot of other things in cancer care, including waste, things we do that we shouldn't do, that really can benefit from a very broad approach to through episode-based payment. Episode-based payment should incentivize good care and good outcomes. Something we don't talk a lot about is the incredible administrative costs of our fee-for-service system. If you saw the, now we're a $4 billion a year business. If you saw the billing operation at MD Anderson, you would be blown away. The sending a bill, collecting a bill, what that happens on the insurance company side of all of these claims is a massive undertaking. Denials, talking to the doctor, all of this is a huge infrastructure. With episode-based payment, one claim, one payment. Just think about that in terms of administrative costs. And in terms of other objective options, we don't want to move to a national health system where we get a global budget. We don't want to be like Canada. I had a call from the health system in Alberta saying, can you give us some help on redesigning our care system? And we don't want to revisit capitation because that really hurt things in California. So a number of years ago, I guess it was about 18 months ago, we all sat in this same room and we heard some very, very passionate descriptions as our committee that was charged to look at the quality of cancer care in America for an aging population. We started looking at some of the potential solutions, and 18 months ago there was a 2-day session on the costs of cancer care, and we heard great presentations, and Lee just came in the room. I'm not Lee Newcomer. I forgot to make that disclaimer. And I'm not Peter Bach talking about episode-based payment. But at that session 18 months ago, we heard from Peter, and we heard from Lee, and we heard a passionate presentation from Zeke Emanuel, who at the time said we wanted episode-based payment for cancer care in the Affordable Care Act, and we weren't able to get it there. But let's do it now. And we all got very excited about episode-based payment. And yet in the Institute of Medicine sort of format of having anything that we say in a report be evidence-based, we were very nicely reminded at the next session that there was no evidence that episode-based payment in cancer care improved outcomes or controlled costs, and we had better temper our recommendations. And so in this wonderful conceptual framework where we put patients at the center and included quality measurement, but with a tremendous emphasis on patient outcomes and costs, and as we heard earlier, not process measures, but actual outcomes, that needs to go to new payment methods that can help us produce an accessible, affordable, high-quality cancer care for our patients. In those recommendations, recommendation 10, and Patty knows all the numbers. I was intrigued at dinner last night that when we started talking about something, she said, oh yeah, recommendation 2. But recommendation, which is great, and we really want, I think one of the things about IOM reports is we really want them implemented. This is where I really want to see this implemented. CMS and others should design and evaluate new payment models. Note, we didn't say episode-based payment, but new payment models. And if evaluations of specific payment models demonstrate increased quality and affordability, CMS and others should rapidly transition from fee-for-service reimbursements to new payment models. So that was our conceptual framework. What's going on now? I would point out that Zeke didn't get his wish. Bundled payments for cancer did not appear in the Affordable Care Act. Bundled payments for other things did. There were other demonstration projects. Our team could find no evidence for its effectiveness, but we need that evidence. Just within the last year, a coalition between RAND and Brookings have been looking at alternate payment models, including bundled payments. CMS and CMMI have told us that as of June or July, they are going to issue a request for demonstrations of new payment models, but not specifically episode-based payment. Almost a year ago, I got a call from Zeke Emanuel saying the Center for American Progress wanted to do a pilot of episode-based payment for cancer. And a number of us in the room went there to hear what Zeke had to say. And he said, well, we really need to do this. It should have been there in the Affordable Care Act. It isn't, so let's do it. And let's do it for lung and colon. And to make a very long story short, a number of times we had CMS in the room, and there was a lot of reluctance on the part of CMS. And as what we learned was that CMS doesn't have a lot of oncology experience. And so our best likelihood of getting episode-based payment models going is with the private insurance sector, and we believe in that. Now, we've been working on episode-based payments in terms of leading up to it for 4 years, and I'll tell you a little bit about what we're doing. There's at least one other major provider in the Northeast who's working with, again, a private insurer to develop episode-based payment programs for cancer. And the AMA and ASCO have proposals, but I think they come a little bit short because they're related to physician proposals. And what I'm going to talk to you is about the entire cancer care experience. So at MD Anderson, we feel we can do this. Why? Because we are a fully integrated practice unit delivery system that I think is ideal for modeling this type of patient. What do I mean by that? It's not just medical oncology and pharmacy and drugs. We have medical oncologists, surgical oncologists, radiation oncologists, specialized imagers, specialized diagnosticians who do pathology. We have anesthesiology, critical care. We also have in our world internal medicine, pulmonary, cardiology. Believe it or not, we have a cardiac catheterization laboratory, which some of us thought was crazy, but we have it. So we have it all in one place. All of our physicians are salaried. So everything is bundled, including our inpatient and outpatient care. We also believe that we want to be paid for the value that we provide our patients. We believe we provide better outcomes. We want to be able to demonstrate that our outcomes are better, and we want to be able to be paid for the cost of the care that we deliver in a fully sort of open manner. And we believe, and I believe particularly as we've gone into this pilot, that as we present this to clinicians, this will drive the incentives to control costs down to the providers. And the providers are not shying away from this. They are embracing this. They think this is a good idea, as we do. So when we started these projects, we decided we would have 3 specific aims. That any bundle that came up had to reflect our true costs of the care that we were providing. And that those bundles had to reflect the entire multidisciplinary care experience of the patient. And finally, and I think extremely important, is that the bundle needed to be tied, whether it was pay for performance or pay for reporting, to meaningful, measurable outcomes. And each of those three words are important. They had to be meaningful to the patients, and they had to be meaningful to the providers. They had to be measurable, and they had to be outcomes, not processes of care. So let me just digress a little bit on one of the key problems, the reason we've been working on this for 4 years, and that is to do the modeling. We have to be able to measure the true costs of care delivery. We have a cost accounting system. Everybody does. We could submit a Medicare cost report. Our cost accounting system is based on the charges. Now, if you know anything about healthcare, you know that our charges are phenomenal. If you saw the Brill article, we cost shifted incredibly in healthcare so that our charges don't reflect our costs. So we needed a system that actually measured costs. Now, for the past 6 years, we've partnered with first Michael Porter and over the last 4 years with Bob Kaplan from the Harvard Business School. Bob is a cost accountant. Until 2010, he hadn't touched healthcare. But at the insistence of Michael Porter, he said, look, why don't you work with these guys? We sent a delegation up to meet with Bob Kaplan and said, Bob, help us. We need to be able to measure our costs of care so that we know when we're treating a patient with a certain condition, we know how much it costs us, not how much it costs the insurer, not how much we charge. Bob said, sure, we do this. Also understand that a lot of this work was developed based on the time our people spent caring for patients. 65% of MD Anderson's budget is personnel, doctors, nurses, and the other 19,000 people who work at MD Anderson comprise 65% of our budget. Drugs are much, much less. So we felt we really had to understand our processes of costing. So we wanted to know, number one, could we do this in healthcare? Could it help us with pricing? And could it help us understand the things with performance improvement? TDABC works through process mapping. We take a team, we sit down, and we look at what happens to a patient for everything that they encounter. And for everything that they encounter in the course of care, this happens to be for our head and neck patients, the new patient registration process, the patient arrives, checks in with a person. That person has a cost rate because they're a receptionist. They cost a certain amount. We estimate a time. We don't measure a time. And these are the basic principles. We add up all of these little interventions. Every once in a while, there are decision points where something happens a certain percentage of a time and certain happens another percentage of a time. All of this feeds into Bob's activity-based costing equations, which, mind you, involve nothing other than straightforward math. There is not a single calculus equation in time-driven activity-based costing. We add all of these up, and we come up with a cost for that particular process. For head and neck cancer, there were over 160 processes that we mapped, tracked, and studied, and added up to come up with our modeling. Now, when we started this process, we chose to model head and neck cancer and early stage lung cancer. Why? Because we had the most experience and we worked with those areas most closely. We found that as we started doing the modeling, it was not the tumor type and stage of disease that determined big buckets of our cost, but it was what the doctors decided, what treatment the doctors decided the patient needed to have. And through our modeling then, the biggest differentiator was the treatment that the doctors selected. And when I say treatment, that relates to, was it surgery plus radiation, was it surgery plus radiation and chemo? And those were the ways these things broke down. And it was fascinating to look at. We then took those simulated areas, those bundled areas, and then simulated the impact of if we bundled the price on what would happen to us with a variety of different numbers in those. And we estimated what our risk would be. ultimately, the risk, which is what everyone's worried in episode-based payment, which is coming now to the payer, was really mitigated by the price point negotiated, as well as a factor for comorbidities. And I'll show you just a little bit about that. Both the price and fortunately our colleague who negotiated with us said, well, you know, we need to also negotiate a stop loss because there are certain catastrophic things that we know that happens to certain patients and when we need to have a stop loss built into that. So those would all be influenced in our negotiations based on our historical finance performance. And finally, there was an understanding that we are a business and we are looking to create a margin because we reinvest in research and future building so that there would be an expected margin and a little bit of a downside protection against the outliers. Now, this was how the modeling came out, and what we had for head and neck cancer was basically 4 different groups of bundles. And these are broken down by the blue bundle was surgery only. The orange bundle were patients who received chemotherapy and surgery, as well as radiation therapy. The more expensive bundles are ones that involved surgery with plastic reconstruction, which obviously is more expensive. And those bundles that were the most expensive were the ones that involved surgery with reconstruction plus radiation or plus radiation and chemotherapy. And if you looked at the box and whisker plots, every one of these and the means and standard deviations are statistically significantly different. The ones that gave everybody heartburn are these outliers that exceeded the 95% confidence limits. But we took it on ourselves to abstract what happened with those patients. And what was happening with those patients were those extreme, unpredictable, not bad care, not stupid things, just the worst imaginable things that happened in terms of bleeding or complications that one couldn't have anticipated. Now, I mentioned that there was a factor for comorbidities. When we broke it out with and looked at the Charleston comorbidity score, if the patients had scores of 2 or greater, and it's a little hard to see here because these are box and whisker plots, but the means and the standard deviations are significantly different when with those Charleston comorbidity scores. So we ended up with 8 bundles for head and neck cancer and began to develop a pilot. We worked with one large payer, head and neck cancer initially. We hope others will follow. We had a simple objective. Not are we going to save money for the healthcare delivery system, for the payer, or for the provider, but could we do this? We thought that the patient population should be regional patients with an established diagnosis of head and neck cancer. And we thought that we would bring, based on what we heard from the payer, an increased number of patients to MD Anderson. That was delightful to our finance team and to our clinicians. We developed a work team approach, put in project management, started to standardize practice, but in the head and neck center they had begun that work already. And our aim is to initiate this pilot in September of this year. The payer will direct newly diagnosed head and neck cancer patients in Texas and the surrounding areas to MD Anderson for their workup and treatment, and will deliver all of the services for a predetermined price, regardless of the services that are utilized. For this particular group, they're newly diagnosed lip and oral cancer patients, larynx, salivary gland, and oral pharynx. You can read the various things, but they go through stage 1 through 4B. We include the costs of clinical trials, but not other diagnostics that we may have to repeat when the patients come to MD Anderson. Project management was a key for both the provider and for us. We've had a great project management team on our side and on the payer's side. Our project management, we divided ourselves up into 6 groups: a finance group, a claims group, a contracting group, a clinical care team, a customer service team, and an outcome and quality measurement team. And in reality, the ones that seem to have the greatest desire to do this, but also some heartburns, are the claims and management, the claims teams for both the payer and the provider, because claims management in this is so much different, and they're having to do a lot of claims management. We're setting up a system to track these patients. This is using TDABC in another study, but we're setting up to be able to track each patient over time as they go through the system, so we know exactly what it's costing us for each patient. We are not going to be telling providers what patients on the bundle and what patients are not. They're all just going to buy into this. The final thing that I want to mention is that we felt that this needed to be something that was meaningful, measurable outcome measures. In order to pay for value, we must measure the outcomes of care. We needed a few measures, and they needed to include underuse measures. We've come to the conclusion we need no more than 5 to 10 outcome measures, including some that are patient-reported. And the ones that we're trying to finalize are survival, quality of life, readmissions, and return to work. So, what are some of the challenges and barriers? Our first challenge was our finance teams wanted nothing to do with this initially. When we started 4 years ago, they thought we were all crazy. They loved being paid fee for service because they knew how to make a margin and they knew how to negotiate contracts. And the details of what they knew was frightening. We thought initially we didn't have systems that told us how much it really cost to deliver our care. We've worked it very hard to find that out. Other organizations around the country are doing the same thing. We wanted to be sure that since the risk was shifting to us, that we knew how to mitigate that risk. And I've told you a little bit about negotiate a good price and negotiate for your outliers with some stop-loss protection. Now, I'd say the biggest challenge outside of a place like MD Anderson is how would you distribute the payments in practices that aren't integrated? And I think that's a huge challenge that our healthcare system needs to decide. Will clinicians embrace it? Ours have. I don't know if yours will, but I think that's a challenge for the future. And I think finally, and most importantly, just as the IOM study pointed out to us, we need to have the data in the peer-reviewed literature that says that episode-based payment improves quality and controls costs, and that's what we're hoping to do. So thank you for your attention, and thank you, Scott.
Thank you very much. I keep things rolling here with our next speaker, Patricia Danzen from the Wharton School at the University of Pennsylvania, who's going to talk about value-based pricing for cancer drugs.